The BMA's Medical Ethics Committee includes elected BMA members, most of whom are elected by the representative body, and 8 members appointed by council with expertise in the law, ethics, philosophy or theology, who contribute enormously to the committee's deliberations. The committee is supported by the 6 members of the BMA's Medical Ethics and Human Rights Department. The focus of our work is providing a wide range of services and products to support doctors in their professional lives. We offer individual ethical and medico-legal advice. We publish advice and guidance, including our main ethics handbook, Medical Ethics Today, and a condensed version, Everyday Medical Ethics and the Law, and other books and short toolkits on ethics and human rights. All our website resources are on the publicly accessible part of the BMA website rather than the members-only section, because we want those resources to be freely available to and used by everyone, including the public and patients, but also by lawyers, politicians, policymakers and the media. We provide training for groups of doctors, medical students and international medical graduates. We monitor developments in medical law, seek to influence the law, and campaign for changes in public policy. We are also committed to defending and speaking out about human rights. The Ethics Department has had a number of staffing changes in the last 15 months as a result of secondments. The constants have been Veronica English and Julian Sheether, the head and deputy head of the department, and 2 of our policy experts, Rebecca Mussell and Sophie Brannan. Ruth Campbell, Martin Davis, Charlotte Wilson, Olivia Lines and Dominic Norcliffe-Brown have worked with us as policy experts for part of the time. The BMA is immensely fortunate in the calibre, professionalism, enthusiasm and commitment of its ethics staff, who are respected national experts in their fields. They are a phenomenal team to work with, and I am immensely grateful for their support. The last 6 months have been unusual, as they have for the whole BMA and indeed nationally and internationally. We have worked solely by email and online. We cancelled the last Ethics Committee meeting of the year, but have continued to consult committee members on numerous issues. The coronavirus pandemic itself created an urgent need for ethical advice. Doctors have been working under extreme pressure, worried about their ability to provide safe and ethical care, to look after their patients, and worried too about their own health and that of their families and friends. With healthcare resources becoming increasingly limited, there were fears that serious health needs might outstrip capacity, and that resource allocation decisions could no longer be made solely on medical grounds. Ethical tensions would arise between concern for the health and welfare of individual patients and concern for populations, with decisions about individual need giving way to decisions about how to maximize overall benefit to provide the greatest benefit to the greatest number of people, the utilitarian objective of equitable concern for all, coupled with the need to maintain vital social functions. Prioritization and triage decisions about how to distribute scarce life-saving resources are professionally, emotionally, morally and ethically challenging. Extreme situations transform, confront and challenge doctors' everyday moral intuitions. In such circumstances, decision-making needs to be open, transparent and accountable. Decisions need to be reasonable, based on the best available evidence and defensible moral principles, made collaboratively and consistently, and designed to promote safe, ethical patient care. And given the emotional and moral distress such grave decision-making can cause, it is essential that doctors and other health and social care workers are provided with the support they need and that their well-being is prioritised. The BMA wished to see official national ethical guidance produced and made that case in numerous national fora. However, the government and its decision-makers were concerned that such guidance might increase fear and suggest that resources might become overstretched. Accordingly, the BMA was the first organisation to fill the gap and to produce guidance, which was so necessary in order to deliver ethical, coherent and consistent decision-making. Our guidance was widely covered in broadcast, print and online media and in the BMJ, and has influenced both public debate and the guidance produced by other organisations. Other COVID-19 related work that we have undertaken has included consideration of the fair and just treatment of the elderly and the disabled, how doctors should respond when their employers fail to provide the PPE required to protect them, given that they are not under an obligation to deliver care irrespective of risk, public-facing materials about advanced care planning during the pandemic, the confidentiality and security of any COVID-19 app and of the COVID-19 data store in England, the development of a policy position on human vaccine challenge studies, and guidance for healthcare professionals asked to remove their beards as part of infection control. Last year, the representative body called for a survey of BMA members to seek their views on the position the BMA should take on a change in the law to permit physician-assisted dying. The Ethics Committee spent much time developing and advising Council about the survey, which was carried out between the 6th and the 27th of February. Nearly 29,000 members responded, giving almost 45,000 free text responses, as well as answering the closed questions in the survey. This is one of the largest surveys of medical opinion ever carried out on this topic. As a result of the cancellation of the annual representative meeting in June, publication of the survey findings has been delayed until after this September ARM, and the debate on policy will now take place at next June's meeting. Our outgoing president, Rhiannon Gillam, the first ever medical ethicist to be our president, instigated and inspired a presidential project on fairness and justice in medical practice. The project included proposing to the World Medical Association the inclusion of justice in the Declaration of Geneva and the International Code of Medical Ethics, an essay competition in which entrants used ethical reasoning and theory to address a practical problem concerning justice in medicine, and a conference which is to be held on the 4th of December. We have continued to publish guidance, including an ethical toolkit for forensic medical practitioners, guidance on patients recording medical consultations, updated guidance on deprivation of liberty safeguards, and updated guidance on the law and ethics of abortion. We have continued to advocate for the decriminalisation of abortion and for the introduction of buffer zones around facilities providing abortion to protect women and staff from harassment and intimidation. We have also welcomed the introduction of telemedicine in abortion provision in England, Scotland and Wales during the pandemic, and pressed for its introduction in Northern Ireland. Early abortion services are now being provided in Northern Ireland following decisions taken in the Westminster Parliament. Such a change is in line with BMA policy. We continue to press for the commissioning of a comprehensive service without unnecessary access barriers in the interests of the health, safety and human rights of women and girls. Some of the other issues the committee has addressed since last year's ARM include ethics support for doctors and medical students, immigration detention, treatment escalation plans, the care and treatment of people with learning disability and autism in Scotland, intersex people, the All Wales DNA CPR policy, obesity as a disease, the confidentiality of genetic information, firearms, safe staffing, and the Romney Report. Other issues about which I have attended meetings include immigration, immigration detention and the health of refugees, overseas charging, the PREVENT strategy and duty, personal demographic data, the Caldecott principles, genomics, clinically assisted nutrition and hydration, mediation in cases of disagreement concerning children and life-sustaining treatment, and contraception. Our work next year will include further work relating to COVID-19, taking forward the debate about assisted dying, continuing to press for the decriminalisation of abortion, defending confidentiality, including the protection of personal demographic data, updating our handbook Medical Ethics Today, probably as a web-based resource, and the conclusion of a major project addressing issues of urgent concern in global human rights. That project will result in a report and will probably address the protection of medical impartiality and neutrality, and indeed medical expertise, custodial settings, immigration, climate change, reproductive rights, organ harvesting, and societal, institutional, and historical racism. A toxic combination of populism, economic insecurity, nationalism, nativism, political majoritarianism, and disregard for the rights of minorities is attacking human rights standards, which are universal, inalienable, indivisible, interdependent, and interrelated. That fundamental attack on human rights threatens the vulnerable, the foreign, the marginal, the displaced, the other. Human rights and the institutional checks and balances that constrain unfettered power in democracies are being challenged by political demagogues. They must be defended because they are essential for protecting human dignity. The BMA has been a leader nationally and internationally in ethics and human rights for more than 30 years. Since the last ARM, I have written letters concerning abuses of human rights in China, Turkey, Iran, Gaza, and Sudan. We have an ethics department because we, as a medical association, have a moral duty to speak out against abuses of ethics and human rights. Indeed, individually, as doctors and medical students, we too have that moral duty to speak out. Doing so is an intrinsic, essential, and ineradicable part of our professional, ethical, and societal responsibilities.